David Pluviose, and welcome to Win the Margins. Today we have as our guest Dr. Gabriela Torres, who is professor of anthropology and associate provost at Wheaton College in Massachusetts. Dr. Torres, thank you so much for joining us. We are excited to have Dr. Torres with us. She is launching a new Mellon Foundation funded project titled Transforming the Future of Health Education, Centering Race and Medical Humanities. This project is a series of faculty collaborations aimed at transforming health education at Wheaton and beyond. And Dr. Torres, I was wondering if you could talk about this new project, why you decided to spearhead it. And I was wondering if you could talk about some of your research and passions that drive your work, Dr. Torres.
Great, thank you. Well, thank you, David. This project really began as a set of collaborations, right? Collaborations that kind of grew out of teaching in the humanities about medicine. So I teach medical anthropology, and in medical anthropology, one of the things that we teach about is the culture of medicine. So what does medicine assume? How does medicine work? What kinds of effects does medicine have on those that it tries to help? And so in many ways, thinking about what are the processes, what are the ways that we come to understand what then becomes the care that we're given. And when I teach these classes, there are a number of students who come from the biomedical sciences. And when they were coming to our class where they were learning about race, and also to the classes of some of my colleagues who are teaching in the humanities, they were really understanding the concept of race as a cultural construct that has real world impact, but we're not finding that that was the same understanding that they were exposed to in their science classes. And so there was a disconnect. And so my students said to me, why is it that we talk about race as a cultural construct here, and in my science classes, that's talked about as if it was a fact? And you're saying it's not a biological fact, and they're not acknowledging that it's not a biological fact. In fact, we're using it as part of the algorithms that determine someone's risk, so that there's different algorithms for determine someone's cardiac risk if they are Black than if they are white. There are different algorithms that are sometimes used for pain in some hospitals, or used to be used for pain. Those are less common now. And so thinking about why is science teaching us of race as a fact? And so that question that our students had began conversations across our campus. So we began to have a back and forth between professors in genetics, professors in the upper level seminars in biology, thinking about how we could have some cross-pollination. They could come to my class and explain how science understands race, and I could go to their classes and explain how we understand the way that science understands race. And so those conversations really gave us the idea at Wheaton that there's a lot more that needs to be talked about, and that the humanities has this ability to provide frameworks for thinking, right? So the humanities thinks about the human experience, like what are the basics of the human experience? It asks the big questions, like what is race? Right? That's a question that resides in the humanities. And what is the lived experience of race is probably the better question for the humanities. And, so we have plenty of novels that are about the lived experience of race. We have ethnographies, which is what anthropologists produce, which are narratives about how race is lived in particular communities. We have artistic expression about the human experience of race. So the humanities in general has a lot of experience thinking about race. And while science uses the concept of race, and uses it as a variable, right? They use it as something that they give to people who they study or people who they care for, right? They don't think about, well, what is it anyway? And is it a biological truth? They know it's not, right? But then they don't question, if it's not a biological truth, what work is it doing in our algorithms or in our diagnostic criteria? And so this project is meant to really begin to provide a curriculum that is humanities focused, that's asking those big questions, of framing race and applying those questions to both humanities classrooms, but also to natural science classrooms. So for example, we're thinking of working with a colleague in genetics to develop a module to talk about genetics and race, and to talk about it from the perspective of the way that anthropology has come to understand it, the way that we understand it in languages and literature, right? How do we understand race and its relationship to genetics? So that's the beginning, and so that's how it started. So it started with faculty conversations that were really pushed for us to have by our students who were questioning the difference, right? And that's sort of the beauty of the liberal arts. That's what can happen in the liberal arts setting, where your students are being made to take maybe a humanities course that they didn't think was that relevant for their medical training, right? And then they're like, hey, this is actually not something that I had thought about. And now I think it's really important, right? And so we've had not just students in their natural science classes, but also students in placements say to us, these variables of race, we're still collecting variables of race when I do my clinical placements or I'm in clinical settings. And I'm not sure what the purpose of collecting those is. Like, what is it? What information are we trying to get at when we collect those variables of race? And having learned in my class, right, that actually they may not give you that good information in terms of what is going on with a person biologically, right? Actually, ancestry might give you a better information, or if you ask about the environment where someone grew up or where someone lived, that might give you information about toxicity that they might have been exposed to, or the legacy of those places. Those things might give you a lot more information than race, which is used really as a proxy for ancestry and location. That's been kind of the beginning where this began. And I can tell you a little bit about how we're going to ensure that we have a plethora of conversations. And so we are going to have a 3-year process of having conversations around these issues. And ultimately, at the end of the conversations, we will have 10 new courses and new modules that will be open access and shareable beyond Wheaton, that could give anyone teaching a humanities, social science, or natural science course who wants to use that module. Assignments, the readings, the class activities that we will prepare, just ready for them to use, as well as instructor materials. So we are assuming that some of the instructors that will access this will have little background on the way that we are framing the issue of race in biology, race in medicine, race in healthcare, right? And so we also are aiming to provide instructional materials for faculty who then use these in their courses so that they feel more competent, including more critical view of race as they teach health.
I was wondering if you'd talk a little about your own research and how your own research informs this work. Interested in your own background and what perspective it gave you as you embarked on this project.
Sure. So, as a Latina woman in the United States, working within medical anthropology, one of the things that first struck me was that cultural background, and Latinos are not a race category, right? They're an ethnicity category, but that our supposed shared cultural background then creates a common experience, right? So coming at it from a Latino in the first place, the idea of race, right, was always tossed up in the air, right? And that really made me want to question, well, how do people from continental Africa and also Black Americans get looped up into this race Black, right? And does that make any sense? So as an anthropologist, I was thinking, does it make any sense to be grouping people who are like Latin Americans from all sorts of different geographic locations together, right? So I think my background, my ethnic background really did shape how I began to look at these issues. So my research background is in violence against women. So that's the focus of my research background, and looking at the impact of violence against women on society. So it's medical anthropology from that perspective. But when you teach in the liberal arts, you start to teach courses that are broader than your area of specialization. And so thinking about medical anthropology really for me came out of the classroom engagement, but really importantly out of my own personal background, right? As a person who really understood that Latinos, for example, were of all categories of race, right? And yet there are consequences for Latinos that are Latino consequences, so that you could ascribe to them because they live in areas that are exposed to great amounts of toxicity, because they're exposed to racialization, right? Because Latinos are also exposed to racialization and discrimination that goes with it, right? And so those have health consequences, when you have to eat it because that someone's just not seeing you in the same way, that has health consequences. So I understood that even if we weren't constituted as a racial group, right, there were still health consequences that came from our ethnic identification, right? So that in and of itself made me really spend some time in my courses teaching about race and questioning it.
It's interesting. The timing of this project is interesting. For those who looked at what the data revealed concerning, let's say, health outcomes amid this pandemic, right? Health disparities, closing health disparities has been the work of so many across the years, but it was just being faced with the stark reality that African American and Hispanic individuals fared far worse overall in the pandemic than, of course, individuals in the majority. Just seeing those disparities revealed in the pandemic definitely created urgency around the work of closing healthcare disparities. And of course, when you talk about students in the health sciences, maybe approaching this, wondering, hey, what does this have to do with giving vaccinations or primary care? Some will say, well, this has everything to do with it, right? Because if you have healthcare practitioners who look like you, that's ideal. But secondarily, who understand something about where you come from, right? The factors and the influences culturally that kind of affect your health, we know will yield so many dividends. And so I was wondering if you could talk about the times that we are in, and what in and around this pandemic have you seen that is super relevant to this work as you seek to promote greater understanding of race among future healthcare practitioners. I wonder if you talk about the times we're in and how they may have informed this work.
All right. And so I think one of the things that struck me about the pandemic was how surprised people were that there were health disparities.
Wow.
You know, like that was actually, that was a surprise, the fact that people were surprised, right? And so when people started to talk, so COVID affected African Americans and Latino Hispanics, you know, disproportionately, in part due to the exposure, right? So the level of exposure that I know some Latino communities in Massachusetts had to COVID was much higher than the level of exposure than, let's say, the suburban community where Wheaton is located, right? And so the exposure was a result of the differences in social inequality, right? For me, thinking about the health disparities, they were already pre-existing, and they were going to be there because structurally people were working certain jobs that required them to be continually exposed to people.
Exactly.
Right? And then they don't have the same level of resources to be sick, to be honest, right? If you, without the pandemic protections that existed for some, right? If you were sick, you didn't get paid, right? And currently, right now, we don't have those pandemic protections. So the exposure continues, right? So if someone's sick, they have to go to work. Right, because that's what you need to do. The problem of health inequities is a really complex one, and it's not a problem that begins or ends at the point of getting in a clinical setting and seeing a physician. It pre-exists that interaction between physician and patients, and thinking about it that way is important, because when the physician is in that room, what actions the patient is going to take in terms of taking up the advice that the physician gives is going to depend on their ability to take their advice, right? So you also saw during the pandemic a lot of conversations around, you know, people need to follow the rules, people need to take the vaccinations, people need to think about how they're protecting the rest of the society, but they didn't think about the long histories that people are implicated in, right? And so, you know, for example, I can speak about my own background, and my background is Guatemalan, right? People are very scared of vaccinations, right? Because in Guatemala, the U.S. Public Health Service had a historical project of actually introducing syphilis. And so they introduced syphilis into the Guatemalan populations. Guatemalans know this. They're scared of vaccinations, so they're very resistant to it, right? They're resistant to having that happen to their communities, because when it's happened in the past, it has not been to their benefit, right? So that resistance that the doctor might see at the clinical setting, that resistance is not resistance that is baseless, right? That the person simply being non-compliant is that they're judging all the information that they have to keep themselves safe. So the lack of historical lens was also something that I think was present during the pandemic. History is humanities. And so that's why I think thinking about race from a historical perspective and thinking about race in medicine from a historical perspective is really important. Medicine has a very long history of having used racialized populations as guinea pigs, right? And that came into play when the vaccinations came out, right? And so, you know, thinking about what does it mean if someone refuses a vaccination because they have an allergy, and what does it mean if someone refuses a vaccination because they actually feel that they can't trust the system that's vaccinating them. We tend to give more moral weight to one than the other, right? So really what we were playing out in the pandemic were inequities and ways that we relate to the state and ways that we relate to each other, how we moralize people's medical decisions in different ways that pre-existed the pandemic altogether. This project is trying to get us to come back to talk about those big questions, right? Questions of morality. How do we moralize medical decisions that racialized persons make, right? That's another really important dimension of race in medicine. And what might history have to say about the ways that medicine understands that in the clinical interaction, and about that ways that people understand that in their lived experience. So those are the things that I was really struck by from a humanities perspective about the pandemic. I think in terms of the specific inequities, it was, when the pandemic started, I actually was teaching a course on global health, right? And it was my last class. I told the students, when we have a pandemic, we actually looked at what was going on in China. And I said, when we have a pandemic, it usually takes 5 years to get a sense as to what that pandemic was actually about. What did it mean? How we understand the disease and its spread, we'll need 5 years to get at the data. So I had said that in our very last class before we got suspended. But in this pandemic, because the flow of information was much faster than in any other pandemic, what we saw this incredible availability of information. And that's actually something that was really, really interesting, right? And what was communicated in that information that came about the pandemic was highly racialized and actually almost stigmatizing of some populations over others, right? Yeah. And so thinking about the questions of how we communicate about medical knowledge in racialized ways is also something that we're doing as part of this humanities focused project, right? So when we think about the kinds of modules that we want to build modules that talk about race from all the different vantage points that the humanities engages with the human experience. And so that's how we're using the example of a pandemic, that's how we're thinking of approaching race in medicine, from these big questions and all those big questions were present in the pandemic. And so, why this now? It's because we got to think about all of those and got to think that in some ways, there is insufficient information in biomedicine to deal about the social problems that I think many times we confuse as clinical problems that are between patient and doctor. Often what's being tried to resolve there is a much broader problem.
No, I was wondering if you talk a little bit about this concept of fusing the humanities and medicine. Of course, of late, there's been a major push to increase the number of, STEM graduates, people pursuing careers in STEM. And I think I saw an article just yesterday talking about a market decline in those, pursuing degrees in the humanities. But the work that you are doing is highlighting the reality that effective healthcare delivery and effectively closing healthcare disparities will take understanding beyond simply hard sciences. And I was also going to talk about this concept of fusing humanities and medicine in education. You mentioned students will come and say, man, how is this relevant? I've got chemistry, I've got physics, I have all these courses I have to take. Why am I taking this? I was wondering if you talk about, from your perspective, this concept of the role of humanities education for those pursuing healthcare careers. I want to talk a little bit more about that.
What humanities education does for people who pursue medical careers is have them think about their role in the reproduction of a system that is replete with inequality. That's a key thing. So medicine is not neutral. It's part of power structures that exist, right? And often when students are taking biology, chemistry, physics, they're not thinking about the power inequalities, that training is going to place them into. They're not really thinking about that, and they're not given space to think about that. Without the humanities, they're also not given space to talk about the ethics, at least in the undergraduate preparation. So medical ethics, which is part of something that we teach at the college, is a really important preparation to think about how am I going to work as a physician, as a PA, as a nurse, right? How am I going to do that work in the future, right? But really importantly is, what will that work mean to me? And what will that work mean to my patients? And so that's the realm of narrative medicine. When we think about narrative medicine, we think there is a narrative that ascribes meaning to what the physician is doing in their interactions with patients. There's a narrative about how the patient feels about their illness, how the patient feels about their interactions with physicians, how the patient feels about their illness's relationship to society at large, right? There's lots of narratives about the human experience. And then there's a narrative of the human experience of that incidence of exchange that happens between physicians or clinician and patient. You know, what happens when I go into there's a narrative of like, I go into the doctor's office, they ask me to put on a gown, I sit really cold with my gown, my feet are cold, I feel like really uncomfortable. That's a narrative, right? And that's a narrative that will shape that interaction, right? And so the humanities, which is versed on creating and taking apart narratives of human experiences, can give biomedical sciences huge amounts of insights for the clinical experience, right? So if you have an anthropologist, a medical anthropologist, observe your interactions with the patients, they could probably tell you that every time you're on your computer, not telling them what you're doing, the patient is feeling probably quite anxious, is shifting. So they could tell these things by the observation. They could then ask patients how they felt about those interactions, and they could point to changes that could be made to make those interactions more culturally competent, if that's what you want to do, or to just be more aware of the feedback that you're getting from the patient in the moment. So there's lots of ways that humanities could inform the student, but there's also lots of ways that humanities could inform the medical space. I'll give you like a really good example for one of my students that I saw. So one of my students did a spatial analysis of a ward that had the MS clinic together with the wound clinic in a hospital in the area. And they share this space, but you can imagine that they have very different needs. So wounds have very different needs from MS, right? And so if they share a space, the kinds of patients that they're seeing differ, right? The ways that they're going to use the space differ. And that creates vulnerabilities for certain patients that over others. So her job was really to think about what are the ways that we could rethink this space, right? To provide better care, right? And what are the narratives of doctors, clinicians, when they treat patients in those spaces, and what do they say about what's working and what's not working, right? That is the job. That's the job of the humanities. And so, for example, this student, what she came out of was like, oh my, there was this whole area of work that needs to be done that I didn't even know existed. Right? For which, hospitals do hire for. They do hire consultants to do that work. User experience consultants, right? In which humanities people actively work in, right? And so it brings humanities scholars, like humanities students, into the work of medicine. And it also allows pre-health students to think about, what does it mean when I become a physician or a clinician of any type? What will it mean to me? What will the work look like? What will I be assuming? Does this fit with my value set? So those kinds of questions are the questions that, or the products that we get out of putting together humanities and natural science in health, thinking about health.
My last question is with regards to the goals of this project. You mentioned that the idea is not, of course, just to impact Wheaton, but to ultimately create a resource that could be available to obviously other institutions. And so I was wondering if you could talk about the ultimate vision of how this project could impact healthcare education across the board. What would you like to see ultimately from this project?
I think ultimately we would like to see colleagues find the work that we do useful for their classrooms in humanities courses, but also in medicine courses, pre-health courses, nursing courses. So we'd like it to be useful and used. We have a robust plan to engage with colleagues at different conferences and show them what we're offering. In terms of these, we have a plan to publish on the pedagogy around these modules. So we have this as part of our plans because we want the resources actively used. A second part of the goal is we'd like to inspire colleagues in other institutions to provide open access resources on these topics so that we can begin to create shared curricula that are easy for faculty to use and to get an ability to access information that actually might be really important to how they teach students, but for which they haven't had any professional development to develop. Faculty, when they are working, right, they might go to disciplinary conferences, and this is probably not a topic that they would find at a disciplinary conference, right? How do you teach about race, right? And so this would be it would be helpful for us to see other colleagues being inspired to learn more and to then produce more open access resources for their peers. Humanities scholars can only go so much in changing the curriculum of natural sciences, but I think we can help natural scientists think about what are the areas that require change and how might they incorporate some of the scholarship that we've been developing for years into how they teach and ultimately how their students provide healthcare. So we really do want to inspire people to use, but also to people to create.
Well, Dr. Torres, I thank you so very much for joining us here in the margins. This project, fascinating, and the potential really for change is tremendous with it when it comes to really promoting greater understanding of issues around race when it comes to healthcare delivery. Thank you for your time. Appreciate your research. I'm looking forward to hearing more about how this project develops. Thank you so much for joining us.
Thank you so much, David. A
All right.
real pleasure.
All right, take care.